Hello everyone, my name is Tia and I'm the PGY2 Oncology Pharmacy resident at AU Medical Center in the University of Georgia College of Pharmacy. Today I will be discussing the evaluation of initial empiric dose reduction of tyrosine kinase inhibitors for patients with metastatic renal cell carcinoma. I have nothing to disclose regarding this presentation. Tyrosine kinase inhibitors are routinely used as first and subsequent line treatments for metastatic renal cell carcinoma. Up to 95% of patients have been reported to experience toxicities which can result in reduced dose intensity, drug interruption, or treatment discontinuation. Current studies support lower starting doses in other cancer types such as lung cancer, metastatic colorectal cancer, and hepatocellular carcinoma. Evidence in metastatic renal cell carcinoma is limited, as only one drug has been assessed, as well as conflicting conclusions have been presented. Despite limited evidence, empiric starting dose reductions of TKIs for metastatic renal cell carcinoma are seen in clinical practice at the Georgia Cancer Center Lenny Walker campus based on a variety of factors, which leads us to the purpose of our study. The purpose of our study was to evaluate how many patients with metastatic renal cell carcinoma were initiated on reduced dose TKIs and if they experienced differences in clinical outcomes. The primary outcome was evaluating how many patients received a reduced dose starting dose of TKI for metastatic renal cell carcinoma. There are multiple secondary outcomes evaluated, including survival, toxicity frequency, as well as leading to an intervention, and duration of therapy. Interventions were defined as further dose reduction, drug interruption, and drug discontinuation. This was a single-center retrospective chart review looking at patients with metastatic renal cell carcinoma that received TKI therapy from January 1st of 2015 through June 30th of 2020. Patients were at least 18 years of age with a diagnosis of metastatic renal cell carcinoma and had received one of the following TKIs: sunitinib, pazopanib, cabozantinib, lenvatinib plus everolimus, everolimus alone, or axitinib. Those receiving adjuvant sunitinib or axitinib plus an immune checkpoint inhibitor were excluded from the study. For each patient included, demographic and treatment history data were collected. Descriptive statistics were used for the primary outcome with either chi-square or two sample t-tests. A Kaplan-Meier curve was used for the secondary outcome of survival. For all other secondary outcomes, non-parametric Fisher exact tests or Wilcoxon rank sum tests were used. 42 patients were included, with 28 in the reduced dose versus 14 in the full dose group. Overall, patient demographics were similar. A majority were Caucasian males with a baseline ECOG performance status of 1 and an intermediate IMDC risk classification. Of note, more patients in the reduced dose group had received prior immune checkpoint inhibitor therapy, but it was not found to be statistically significant. For the primary outcome, 28 or 66.7% of patients received a reduced starting dose versus 14 or 33.3% received full starting dose of TKI for their metastatic renal cell carcinoma. A Kaplan-Meier curve was completed to assess survival between the two groups. On the y-axis is the survival probability, and on the x-axis is the time to death. Survival was observed to be longer in the full dose group, but it was not statistically significant. Of note, 3 patients were still on reduced dose therapy, and 2 patients were still on full dose therapy at the time of data cutoff. Additionally, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a full dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiving a reduced dose, 22 out of 28 patients receiv were enrolled in 2017 or later versus 14 out of 14 patients receiving a full dose were enrolled in 2017 or earlier. Therefore, these points could have contributed to the results observed with survival. As we saw with the previous slide, there were no differences observed in mortality or time to death. Treatment duration was observed to be shorter in the reduced dose group, but not found to be statistically significant. This could have also been influenced by the enrollment patterns of each group. In terms of interventions that were made, about half of the patients in each group had further dose reductions, with toxicities being the most common indication. 5 or 21.7% in the reduced dose versus 3 or 33.3% in the full dose had dose interruptions, with toxicities being the most common indication. Lastly, 19 or 82.6% in the reduced dose versus 9 or 100% in the full dose had their dose discontinued, with disease progression and toxicities being the most common indication. None of these points were found to be statistically significant. There are several limitations associated with our study. The sample size was small and the study was retrospective in nature, therefore it may not have been powered to detect the difference between groups. After review of the Kaplan-Meier curve, several other limitations were discovered. Several patients were still on therapy past the cutoff date of the study, making the survival data immature. Additionally, the providers seeing the patients in clinic used reduced starting doses more commonly in the later half of the data collection window, impacting treatment duration as well as time to death for the reduced dose group. Our study observed more patients being started on a reduced dose TKI for metastatic renal cell carcinoma, with no differences in survival or interventions. Ultimately, larger prospective studies need to be conducted to determine if starting reduced dose TKIs in metastatic renal cell carcinoma will improve tolerability without compromising efficacy. I would like to acknowledge the following team members. And here is a self-assessment question for the presentation. What was the most common justification for intervention or interventions made for a patient's TKI therapy? And the correct answer is B, toxicities. That is all that I have to share regarding our project. Thank you for listening in. If there are any questions, please feel free to reach out to me in the Q&A session or email or at my email listed on the slide here.